I think they are very exciting because they appear so far to be able to accomplish dramatic drops in the LDL cholesterol, which has been a therapeutic target and well established that when you lower it, it does good things as long as there's no off-target problems of the drug. So I think they're very exciting. We will see some data here. In fact, we saw it this morning in the late breakers that trials not designed to look at outcomes suggest that outcomes are short-term outcomes at 12 and 18 months are better in the intervention arms. Nevertheless, we need those big outcome trials, many of which are in progress, and we will have results. I don't think this year for the large outcome trials for CVD, but the anticipation is that some of these agents, one of them may be approved final quarter of this year or certainly next year for familial hypercholesterolemia, which remains a less of a problem from a population standpoint, but nevertheless an important problem that statin therapy has not fully addressed. So we think these probably will be approved. These are injectables. The one that likely will come to the market first ideally will be injected every 2 weeks. There's one that will likely be approved much later that could be injected every 4 or 8 weeks. So that's a little bit of a hurdle as we see patients with diabetes reluctant to go to insulin because of the injections. That's an issue for drug delivery. These are a brand new class of medications, monoclonal antibodies, likely to be priced very expensively. Lots of research and development, lots of time spent developing, and I think the industry will want to recoup those costs. That said, there's a bunch of them out there now. So maybe like we saw with the Hep C drug and the two new Hep C drug manufacturers, I won't name names, kind of in a bidding war, competition serves the consumer. I think we have to be a little careful about industry driving the bus here. There's been a lot of, renewed interest in identification of family kindreds who have familial hypercholesterolemia. That's fine, but I mean, we should have been doing that 10 years ago. We have statins. Statins basically have turned a lethal disease into a chronic management disease. So whatever the new strategies are, it's probably being driven by folks who would like to demonstrate that adding these monoclonal antibodies to statins will save more lives. And so then you're going to need not only number needed to treat, because hopefully number needed to harm is going to be very, very high. They look safe so far. They look safe, but we'll need large numbers to talk about safety. But you're going to need number needed to treat and then cost per life year gained. And if that's more than $10,000, $20,000, or $30,000, we're all going to say, really?